For your patients with hard-to-control hypertension, are you struggling to achieve blood pressure goals despite treating with at least 2 antihypertensive medications? Uncontrolled hypertension increases the risk of death and stroke for many patients. Not all hypertension is the same. For many of these patients, you may want to consider a different pathway. Aldosterone may be to blame. Visit blamealdo.com to learn more.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hello, CardioNerds. Welcome back for another episode of our Atrial Fibrillation series. We are so excited to take a deep dive in the world of atrial flutter today. My name is Colin Blumenthal, and I'm here with my AFib co-chair, Naima Maqsood. Naima is the FIT ambassador for Temple University Hospital and is chair for the EP Subspecialty Council.
Awesome. Thanks so much, Colin. I'm so excited to learn from a very special guest and renowned educator, Dr. Josh Cooper. First, I'll hand it over to Dr. Akiva Rosenzveig, who is an internal medicine resident at the Cleveland Clinic. He is also the director of internship for the CardioNerds Academy and the lead for this episode.
Thanks so much, Naima. I have the absolute privilege of introducing Dr. Joshua Cooper. Dr. Cooper is the director of cardiac electrophysiology at Temple University Hospital and professor of medicine at the Lewis Katz School of Medicine at Temple University. Although he has won many awards and accolades over his tenure, many of you may know him as @NarrowQRS on X or Twitter, or from his YouTube channel where he has educated thousands, from patients to trainees, from medical students to EP fellows and staff, on various concepts within electrophysiology. Thank you so much for joining us today, Dr. Cooper. We are so excited to have you on CardioNerds and, more importantly, to learn from you.
My pleasure. Thank you guys so much for the invitation. I really appreciate any opportunity to educate, and we'll just have a good time talking about EP.
Awesome. It's such a pleasure having you on, Dr. Cooper. All right, let's kick this episode off. Some may remember the year 1911 as the year of the first automobile electrical ignition system, the year of the first International Women's Day, or perhaps the year that the Mona Lisa was stolen from the Louvre. However, we, CardioNerds, remember 1911 as the origins of the "what makes your heart flutter" question. In 1911, Jolly and Ritchie from the University of Edinburgh were the first to describe the characteristic sawtooth waves on EKG of what was then referred to as auricular flutter, and thus they were the first to distinguish flutter from fibrillation. However, from the first documented observation of atrial or auricular fibrillation by William Harvey in 1628 until the present, AFib and flutter have been inextricably linked. So, before we head over to the CardioNerds Arrhythmia Clinic, Dr. Cooper, would you please help us understand the relationship between atrial fibrillation and atrial flutter?
Yes, it would be my pleasure. I agree with you that atrial fibrillation and atrial flutter are often used in the same breath. People will even call something fib flutter if they look at an EKG and they're not sure which one it is, because I think the distinguishing features of each are not always appreciated on EKG. And the management, as we'll discuss, is different between the two. So I'm really excited to be able to differentiate the two so that people can distinguish them and then figure out how to manage them in individual patients. So basically, atrial flutter is a very organized rhythm. It is a wavefront that travels around and around the same boring circuit over and over again, creating reproducible P waves or flutter waves on the surface EKG, which each look identical to each other because it is the same sequence of activation in the atrial chambers. They are the same distance apart because it is the same rate over and over again. And there's often a very mathematical relationship between the atrial activity and the ventricular activity, as we will discuss, whether it is a 2-to-1 or 3-to-1 or 4-to-1 or changing relationship, but with very predictable discrete intervals. In contrast, atrial fibrillation is a chaotic rhythm that is ever changing, that consists typically of firing spots, little local short circuits that interplay off each other. And there are really no two events or beats. You can't even really describe them as beats, but no two events that are the same as each other because it's truly a chaotic, ever-changing pattern in the atria. And therefore, the output in the ventricles is also chaotic and irregular. it is important to distinguish them, not necessarily because of the basics of treatment, which, as we will discuss, consists of anticoagulation to reduce stroke risk and rate control to ensure that the patient doesn't have excessive tachycardia, but because the forecast of recurrence is very different depending on treatment, in particular the response to ablation. And we'll, of course, get into that with our case examples. The atrial flutter is often seen in isolation. You may have patients who present with atrial flutter and they have not had atrial fibrillation. In contrast, patients who have atrial fibrillation may often present on occasion with atrial flutter as well. Somebody who has only had atrial flutter that has been treated may eventually develop atrial fibrillation because one of the common threads of pathophysiology between the two is that of fibrosis and slow conduction in atrial tissue. Atrial flutter typically being in the right atrium, a short circuit, as we'll talk about, round and round the right atrium, when atrial fibrillation typically being more left atrial based with multiple little circuits because of excessive fibrosis in left atrial tissue. But the point is that as people get older and fibrosis becomes more prominent in all of our hearts, each of these rhythms becomes more common. And again, flutter may be an earlier observation in some people, with atrial fibrillation coming later. Once somebody develops atrial fibrillation, atrial flutter may be part of that complex as well. And I think we'll stop there and proceed.
Thank you so much, Dr. Cooper, for that excellent explanation on the distinction between atrial fibrillation and atrial flutter, both on a pathophysiologic basis and also in terms of management, which we'll get to. So I guess now that we have that understanding, that basis, we can head over to the CardioNerds Arrhythmia Clinic to see a new patient. So this patient is Al Flutowski, a 45-year-old man with history of hypertension, hyperlipidemia, diabetes, class 2 obesity, and sleep apnea, who presents after endorsing occasional palpitations to his primary care doctor, who then obtained an ECG that showed that he was in typical atrial flutter with 2-to-1 block and a heart rate of 150 beats per minute. His primary care doctor started him on metoprolol succinate 200 milligrams daily, apixaban 5 milligrams twice a day, placed a Zeo patch, and referred him to you for further management. Dr. Cooper, before we talk about management for Mr. Flutowski, can you please describe right atrial anatomy and the different atrial flutter circuits that one might see?
Absolutely. I first want to mention a couple points about this gentleman's presentation. The heart rate of 150 is very classic and typical for typical flutter. And the reason is that the most common flutter circuit that patients may have is a circuit that circumnavigates the tricuspid valve. The pathway of activation travels round and round, typically in a counterclockwise pattern, looking at the right atrium from the perspective of the right ventricle, looking up through the tricuspid valve. You have this counterclockwise circuit that travels up the septum from medial to lateral across the right atrial roof, down the lateral right atrial wall, and then back toward the septum, lateral to medial across the floor of the right atrium between the inferior vena cava and the inferior margin of the tricuspid valve. And that floor component is known as the cavo-tricuspid isthmus. It is the narrow portion between the wider medial and lateral aspects of the right atrium, and it is a critical part of the typical flutter circuit. And the reason I'm telling you this in the context of the heart rate of 150 is that the reason that people typically present with heart rates in the 140 to 150 range is that the tricuspid valve is the barrier around which the flutter circuit travels. And the tricuspid valve is of a relatively constant size, and atrial tissue has a relatively constant conduction velocity. And therefore, atrial flutter that travels around and around the tricuspid valve through right atrial tissue has a pretty constant rate without being on any medications. And that rate is typically at or close to 300 beats per minute. Because the human AV node typically is incapable of conducting beats at 300 beats per minute, typically every other beat in an untreated patient with flutter will travel through the AV node down to the ventricles, resulting in a heart rate in the ventricles that is half that of the atria, that being typically around 150 beats per minute. And so then again, that's called typical flutter. It's interesting to note that one can have the reverse sequence in the same path, clockwise right atrial flutter, where it is exactly the same circuit around the tricuspid valve, but in the clockwise direction. And that typically has the same rate. And there are other types of flutter circuits that can exist as well, although usually patients will have some other type of cardiac history. For example, if somebody has a history of cardiac surgery, whether it is bypass surgery or valve surgery, in these scenarios, there will be man-made iatrogenic scars that are formed typically in the right atrium, whether it's simply a cannulation site from going on cardiopulmonary bypass, or whether it is an actual incision that is made in the right atrial free wall in order to operate on the tricuspid valve, or an incision in the right atrial wall and the septum to get to the mitral valve, which is one of the surgical routes to do mitral valve surgery. You've now created, once the incisions are sutured, a fixed barrier, a scar barrier across which signals do not travel. And now you can have an atypical flutter circuit that travels around one of these barriers, known as scar flutter, incisional flutter, surgical flutter. And these can also be located, as I said, in the right atrium, but not involving the cavo-tricuspid isthmus on the floor. The appearance of the flutter waves on EKG will differ depending on where the circuit is located and the direction it revolves. Typical flutter has negative sawtooth waves, as has been known for decades and perhaps centuries, as you described before, where there is a gradual downslope in leads 2, 3, and AVF of the flutter waves, and then a more rapid rise at the end of each flutter wave. And conversely, in clockwise flutter, you typically have more positive deflections of the flutter waves in the inferior leads. Interestingly, in both clockwise and counterclockwise right atrial flutter, the polarity of the flutter waves in the inferior leads is typically opposite that of the polarity in lead V1. So if you have negative flutter waves in counterclockwise typical flutter in the inferior leads, you typically will have positive flutter waves in lead V1, and the opposite scenario in clockwise isthmus-dependent right atrial flutter. To be complete, there are other flutter circuits that can exist in the left atrium, for example, mitral flutter, more commonly seen in the context of patients who have atrial fibrillation as well because of the fibrosis in the left atrium, pathophysiologically being important for both, and also often in patients who have had previous ablation, creating additional barriers, not a surgical incision, but areas where ablation has been performed, whether it is in a linear fashion that is incomplete, or whether it is a circular set of lesions, for example, around each set of pulmonary veins. And you can get, therefore, atypical left atrial flutters that revolve around those barriers. For example, something called roof-dependent flutter, which would be a circuit that travels around the left atrium, circumnavigating the lesion set that maybe have been made in a previous atrial fibrillation ablation around the left pulmonary veins or around the right pulmonary veins, traveling through the roof, down the posterior wall, around the veins, and back around, or conversely in the other direction. The reason that these are important is really for treatment. Again, the treatment from a medical perspective would be anticoagulation and rate control and possibly cardioversion, and we'll get into that. But when we in the EP world are thinking about catheter ablation, which is, as we'll discuss, usually curative, we like to be able to plan and counsel the patient what might be involved in their procedure, how complex it may be, what the risks of right atrial versus left atrial procedures may be. And I think that's all and more that you wanted to know about various flutter circuits in the right and the left atrium.
Awesome, Dr. Cooper. That's a great point. It kind of forces us to think not just about what's on the EKG, but also potentially the patient's past history, any surgical procedures or ablations they might have already had, and thinking about the potential mechanism of the flutter. So I will also point out to our listeners a wonderful video on Dr. Cooper's YouTube page, which we will link in our show notes, visually illustrating what Dr. Cooper just described. Now that we understand the different types of macro re-entry circuits, let's come back to Mr. Flotowski. His heart rate in clinic today is 150 beats per minute, and his Zio patch shows a rate of 130 to 150 beats per minute. Can you shed light on why rate controlling atrial flutter may be more challenging than atrial fibrillation?
Yes, absolutely. And that's a terrific point. I was a little struck in our hypothetical case at the dose of metoprolol that was started. Typically, we'll start at a lower dose and work our way up. But in this case, on a high dose of metoprolol, the patient's heart rate has not yet come under good control. And the question is why? The answer lies actually not so much in the atria, but in the AV node. As you know, the AV node is that special and unique electrical tissue that serves as the start of the connection between top and bottom, between the atria and the ventricles. And most cardiac tissue has interesting and uniform properties that the faster you stimulate the tissue, the shorter the refractory period and the better the conduction. The AV node behaves in the opposite way. The AV node has properties that is known as decremental conduction. And what that means is the faster that you bombard the AV node, the slower it conducts, the longer the refractory period. It's very unique in AV node tissue. And therefore, if somebody is in atrial fibrillation, where their atria, while disorganized, could be described as having a rate in the 400 or 500 beat per minute range, at least that's how quickly signals are pelting the AV node. The AV node becomes overwhelmed at that rate and conducts off medicines at a particular rate, letting some of those signals through down to the ventricles, creating an irregular tachycardia. If the atrial rate slows, however, for example, in atrial flutter, where instead of going at 500 times per minute, the atria are contracting and sending signals to the AV node at maybe 300 beats per minute or slightly slower, the AV node has greater capability of transmitting more of those signals down to the ventricles because it is a little bit less overwhelmed. And therefore, one needs yet a higher dose of AV node blocking medications, and often a combination of medications, as Mr. Flotowski apparently will need, in order to regulate and slow the ventricular response. And if we were to take that one step further in patients who have a different rhythm, which we're not addressing today, atrial tachycardia, where somebody may have a firing spot that is firing at perhaps 170 or 180 beats per minute or something of that sort, then the AV node is often capable of conducting in a one-to-one relationship down to the ventricles, and that would require even higher doses of AV node blocking medications in order to slow the ventricular response. And it may not even be possible, and one may be limited by the blood pressure lowering impact of those AV node blocking medications before you've even achieved the goals that one has with regard to ventricular rate.
That is such a super interesting point about the uniqueness of the AV node. I also heard about the possibility of one-to-one conduction in atrial flutter. So can you shed a bit of light on the situations that can allow for one-to-one conduction in atrial flutter, and what are the potential consequences of that?
Absolutely. And I think we're going to have to travel back to medical school and think about the action potential for the answer to this question. I mentioned earlier that the typical atrial rate in flutter is around 300 beats per minute because of the anatomic reasons and boundaries and route of the atrial flutter circuit. And the human AV node typically just cannot conduct that fast, which is a good protection. You can think of the AV node really as a filter that prevents us from having life-threatening tachycardia in the ventricles when the atria go out of rhythm. However, if one had an atrial flutter circuit that were slower, the principles that we just discussed before about the AV node come into play. So if somebody were to have, for example, atrial flutter in a different route, a different circuit other than the typical one, where the atrial rate, for example, is 230 or 220 or 210 beats per minute, you may be, especially in younger patients, approaching the point where the AV node is capable of conducting in a one-to-one fashion. And so the same can hold when you have typical flutter in the usual route, and someone gets put on a medication that does not change the route or where the flutter is located, but instead slows the propagation of the wavefront across atrial tissue that is traveling along the same distance, but at a slower pace. And what the specific category of medication that I'm referring to is the sodium channel blocker antiarrhythmic drug category. That includes flecainide and propafenone. These medications block the sodium channel. And again, going back to medical school, you'll think of the action potential and the phase zero depolarization of the cardiac myocyte, which is typically a very abrupt skyrocketing of the membrane potential, which starts at minus 90 and shoots up above zero. And that's due to sodium channel opening. If you were to take a cell and expose it to a sodium channel blocker like flecainide, for example, then that phase zero depolarization component of the action potential will have a more gradual slope. It will take that cell a little bit longer to depolarize. Well, if you think of the circuit as made up of myocytes, each one stimulating the adjacent cell as you travel around the tricuspid valve, if the first cell takes a little bit longer to depolarize, and so too does the second and the third, and on around the circuit, what you've now done on flecainide or any sodium channel blocker is you've slowed wavefront propagation. You've slowed the atrial flutter circuit, even though it is taking the exact same route. And the danger of doing that in somebody who is not also on an AV node blocking medication is that you could slow the flutter circuit to the point where the AV node is capable of conducting one-to-one. And it sounds paradoxical, but we've reviewed why this is the case, that somebody who is in flutter at 300 beats per minute will go at a maximum ventricular rate of 150, whereas somebody who has a slower atrial flutter may have a faster ventricular response. And depending on the age of the patient and the capabilities of their AV node, which roughly but not completely tracks with age, you may get into a dangerous situation. And this is why there is the dictum that in the patient who you prescribe flecainide or propafenone, they should also be prescribed at least one AV node blocker to try to prevent one-to-one conduction of a slow atrial flutter that could result from that antiarrhythmic. To be complete, the other categories of antiarrhythmic drugs, specifically class 3 drugs, potassium channel blockers, such as sotalol or dofetilide or amiodarone, which has actually properties in different categories, those do not actually slow conduction across tissue in the way that sodium channels do. And therefore, you're not as worried about the same risk of rapid conduction of slow atrial flutter. And in fact, sotalol and amiodarone also have AV node blocking properties in and of themselves. So actually will also serve to help with rate control if those drugs are used.
That was an incredible explanation. And I think really just highlights that essentially you have to slow down both components together, right? Like if you're going to slow down the actual wavefront propagation in the atrium, you also have to slow down conduction through the AV node. Otherwise, you can end up with a dangerous pairing there. And Mr. Flutowski, maybe because he got a preview of this podcast and heard about flecainide, maybe because he just likes a quick fix, but he is not really feeling the medication route. And he really wanted to know what the utility of catheter ablation was for his flutter. What is your approach to catheter ablation for atrial flutter? And when would you use cardioversion as a first line approach to quickly put the person back into sinus rhythm? When would you leave them in flutter, and when would you take them straight to the lab? When can you delay and schedule it as an outpatient? What is your approach to the management of atrial flutter in terms of ablation?
Absolutely. So certainly anybody who has atrial flutter could be cardioverted at any point in time. And the decision point on whether to cardiovert promptly and restore sinus rhythm versus delaying in order to get them to a catheter ablation will depend a little bit upon how fast the conduction is going, how uncomfortable the patient, how symptomatic they may be in atrial flutter, and just practical aspects of such things as scheduling and maybe other medical aspects such as cardiomyopathy, congestive heart failure, pulmonary hypertension. So if it is felt that the atrial flutter poses either a medical risk or is causing a symptom or quality of life issue with the patient, that cannot be or should not be delayed, then cardioversion is very appropriate. If the patient, just like a new diagnosis of atrial fibrillation, if the patient has not initially been on an anticoagulant and it is started, for example, in the outpatient or emergency room setting, then one typically would want to wait a minimum of 4 weeks or so on continuous anticoagulation before proceeding with cardioversion. If it is felt that a cardioversion is more urgent than waiting 4 weeks, then one typically would precede the cardioversion with a transesophageal echo to evaluate the left atrium, specifically the left atrial appendage, to ensure that there is no thrombus in the appendage prior to giving the shock and restoring sinus rhythm. It's also important to note that when one cardioverts a patient out of atrial flutter or atrial fibrillation for that matter, there is a post-conversion stunning phase, which is another discussion for another time. But when sinus rhythm is restored, if somebody has been out of rhythm for 2, 3 more days or longer, there is actually a period of mechanical stunning in sinus rhythm where there is not good vigorous contraction after cardioversion. So it is even more important for continuous anticoagulation to be administered following cardioversion, even compared to prior to cardioversion, in order to minimize the risk of stroke. If a patient is, however, stable with controlled ventricular rates and asymptomatic, and we wish to wait to do a catheter ablation procedure, that is fine. And then, of course, when the patient is brought to the EP lab for catheter ablation, the first thing that we do once we get catheters into the heart is prove that what we guessed from the EKG in terms of mechanism and circuit location is in fact true, specifically that the cavo-tricuspid isthmus is a critical part of the circuit. And there are lots of techniques that we use called mapping techniques, looking at the wavefront propagation with special tools in the EP lab. Come by and visit and see what these are, because it's actually visually pleasing. In addition, we can do electrical testing, something called entrainment mapping, which is a pacing maneuver. Again, interesting, and it's also reviewed in the video that Dr. Maqsood referenced earlier. But we can prove where the flutter circuit is. We can place ablation lesions to cut off a critical component, which again is usually the cavo-tricuspid isthmus in typical flutter, across the floor of the right atrium between the tricuspid annulus and the inferior vena cava, creating full thickness burns one next to the other. And that will absolutely cut off the circuit. And the chance of long-term success is well over 90%. And in most series, you'll see a success rate in the 95+% range in the long term. So back to your question of how do you choose between cardioversion or ablation? And sometimes we do both. If the patient cannot tolerate flutter until their ablation is scheduled, one could do a cardioversion and then proceed with ablation, because it is typically an anatomic approach. We're usually quite confident about where the circuit is located, and there are electrical ways of performing a flutter ablation without the patient being in flutter. Sometimes we try to provoke it and pace the patient into flutter in the EP lab and prove that it is typical flutter and then do ablation. But because we are so familiar with flutter and its anatomic barriers, we are very easily able to perform ablation even if the patient arises in sinus rhythm. The circumstances where one might perform a cardioversion only might be if there is a very clear trigger. Somebody presented with pneumonia, or they had cardiac surgery, and they had atrial flutter as a consequence of these unique circumstances. In those cases, then one might perform a cardioversion and then wait and see if the patient ever has a recurrence. And if they have a second episode outside the setting of a clear trigger, then one might elect with the patient to proceed with a curative catheter ablation. On the other hand, one might decide up front, if they have flutter in the first place, because the risks of the procedure are so low and the success rates are so high, that simply crossing it off this patient's list of medical things to worry about might be a choice in a shared decision-making discussion that the patient might make, in which case seeing flutter just once is certainly sufficient to say, let's go to the EP lab, do an ablation, and be done with it. There are implications, perhaps, in the long run in terms of anticoagulation as well. If somebody has only had atrial flutter and we perform a catheter ablation with a very high cure rate, then we might decide to prescribe a particular time frame of ongoing anticoagulation and perhaps doing some heart monitoring to ensure there's no recurrence of flutter and no atrial fibrillation is seen. And then we might choose together to stop the anticoagulation, and that's the end of it. On the other hand, if somebody only has a cardioversion, then they are at risk for flutter recurrence at any point in the future. And depending on their CHADS-VASc risk score, we might choose to keep them on anticoagulation long term. I'll make one last quick point about flutter management, because antiarrhythmic drugs is something that we haven't really discussed in terms of treatment, other than the potential for accelerating the ventricular response to slow flutter. Flecainide and propafenone, as I said, slow the flutter circuit. And from an antiarrhythmic standpoint, that is actually a pro-arrhythmic effect. By slowing the circuit, you actually make it more stable and more likely to sustain and occur. So we actually typically do not use flecainide or propafenone to treat primarily atrial flutter because it doesn't work. It only makes it more likely to occur. In contrast, the class 3 drugs that prolong refractory periods by blocking potassium channels may be more effective at preventing an atrial flutter circuit from recurring. So a patient may choose that route as well. There are studies that have compared antiarrhythmic drugs to catheter ablation, and they go way back. There was one study in 2000, another one in 2006, where small groups of patients at single centers were randomly given either a treatment with antiarrhythmic drug therapy and cardioversion versus catheter ablation. And in both clinical trials, randomized trials, the ablation route won hands down. A dramatic difference in reducing future recurrence of atrial flutter. In one study, the LADIP study, the one I referred to in 2006, there was an over 96% cure rate of atrial flutter in the ablation arm. And I believe it was only something on the order of a 70% cure rate in the patients who had antiarrhythmic drug therapy. So there's a clear winner in terms of prevention of future arrhythmias. And this also may have implications on the future risk of atrial fibrillation, which in the Natali study from 2000, simply doing a flutter ablation actually also reduced the risk of future atrial fibrillation as well.
Wow, thank you so much, Dr. Cooper. That was such an extensive explanation for all the management options, situations in which you might have to consider antiarrhythmic drugs versus cardioversion. And I think for our listeners, it's definitely safe to say that if a patient is able to get it, an ablation is certainly one of the first things you would want to consider or talk to the patient about as far as treatment, because of the great success rate and the chances of potentially decreasing chances of them developing fib in the future. Now, since we're already talking about atrial fibrillation, Dr. Cooper, our patient, Mr. Flutowski, does not have documented atrial fibrillation, but say we were seeing a patient in the clinic that has both documented atrial fibrillation and atrial flutter. What is the utility of catheter ablation for both arrhythmia? So, doing a pulmonary vein isolation as well as cavotricuspid isthmus ablation.
A great question. And as I said earlier, it is not uncommon to see patients have both. Typically, one cannot be in two rhythms at the same time. So this label, by the way, of fib flutter doesn't really exist. An EKG either shows atrial flutter or atrial fibrillation. And again, that's another topic, distinguishing the two. And one of the biggest clues is simply looking at the ventricular response. It's typically very predictable and mathematical in flutter and not in fibrillation. But if patients that sometimes have fib and sometimes have flutter, then typically if we were to do a flutter ablation only, it will not eliminate atrial fibrillation. Occasionally, there's a hybrid approach that can be taken, in large part because, as we said earlier, atrial flutter often is harder to rate control. So there are some patients, perhaps those who are more frail with more comorbidities, where we might want to keep their procedure time to a minimum and expose them to the least invasive and shortest procedures possible, where we might say, let's do a flutter ablation and then put them on an antiarrhythmic and AV node blocking medication combination for their atrial fibrillation, because maybe the flutter, when they have it, is harder to rate control and is more highly symptomatic. But typically, if somebody has both, especially in the current era where atrial fibrillation ablation has become extremely routine and much shorter and lower complication risk than ever before, we typically will do a combination of atrial flutter and atrial fibrillation ablation in order to deal with both at the same time. It's actually interesting to think about the pathophysiology of flutter initiation in the context of somebody with atrial fibrillation as well, because atrial fibrillation typically starts with rapid firing of sites in one or more of the pulmonary veins in the left atrium, throwing the atria out of rhythm into chaos, utilizing areas of fibrosis and slow conduction and multiple circuits to create the fibrillatory activity. But likewise, atrial flutter usually starts because of trigger spots firing in the left atrium. And those will travel over across the septum, usually down through the coronary sinus connection between left and right atrium, and initiate the atrial flutter circuit. And so if one were to do in a patient who has both atrial flutter and atrial fibrillation, only an atrial fibrillation ablation, usually the main component of that being pulmonary vein isolation, then you have closed off and eliminated these trigger spots that can initiate atrial fibrillation and can initiate atrial flutter. So interestingly, if one did only an AFib ablation, then atrial flutter becomes much less likely. And there are even some people who say that we shouldn't even bother doing the right atrial flutter ablation in such patients. But because it is so straightforward and easy to do, you're not near really any critical structures. Typically, most people will do a flutter ablation at the beginning or the end of a combination procedure in order to manage both.
So, just piggybacking off that a little bit. So, we're talking, obviously, we've sort of mentioned here and there that these are sort of birds of a feather, and you often can have one before the other or both happening intermittently but coexisting. In terms of the risk of developing atrial fibrillation after you have had diagnosed and or treated atrial flutter, what is the risk in the short term, say 6 months, a year, of someone developing atrial fibrillation? And what do you do with that patient's anticoagulation and monitoring if that risk is high? So if they already meet criteria for anticoagulation because of their CHADS VASc score, but they have had a catheter ablation with a very high success rate, we don't expect their flutter to come back. But what do you do to be confident that they're not going to develop, say, asymptomatic atrial fibrillation 6 months later after you just stopped their anticoagulation?
A wonderful question. And embarrassingly, I probably am not up on the latest epidemiologic data to answer that with our current state of knowledge. I will tell you that in the short term, it's typically a low risk to see atrial fibrillation if somebody has only presented with atrial flutter. And so typically in my practice and in many people's practice, if we do an ablation for atrial flutter because of the very high cure rate, I will typically leave them on an anticoagulant for a period of time afterward, usually a few months. It depends on the patient, what their risk of bleeding is, what their feelings are about being on anticoagulation. And typically, I will leave them anticoagulated for at least 3 months, sometimes 6 months. And in patients with a higher CHADS VASc score, I might even leave them on it for a year. And if they haven't had any clinical atrial fibrillation, at that point, I might stop it, but being aware that they are at higher risk. Certainly, somebody who has had a history of atrial flutter is likely at higher risk of developing atrial fibrillation, but that may come years later. And so, as with any treatment in medicine, the risk benefit balance needs to be addressed. And the question is, if somebody may not have atrial fibrillation for years, is it worth taking the risk of being on continuous anticoagulation in the interim while we're waiting for something that may or may not even ever happen? In the current era, we are blessed. It's a blessing and a curse, but mostly blessed with the ability to monitor patients' rhythm in the long term. And that could take the form of an implantable heart monitor, which we may use in patients who have a high CHADS VASc score in order to be darn sure that we catch atrial fibrillation if it were to occur. These small monitors can be put in under the skin. They're the size of a paperclip. It takes about 30 seconds to do, and they have batteries that last over 4 years. So there are patients we can simply do monthly checks from this implanted heart monitor and take them off anticoagulation to see if they have any atrial fibrillation. Then we can always know right away and put them right back on their anticoagulant in order to reduce their stroke risk. But in addition, patients have Apple Watches and other devices where they may be monitoring their own rhythm in the long run. And many of these patients are symptomatic. So simply waiting for symptoms is another clue. But the asymptomatic patient is the fear that we all have. Nobody wants a patient to end up with atrial fibrillation, off a blood thinner, with no one knowing about it for weeks or months at a time, exposing them to a higher risk of stroke than they might have had if they were on an anticoagulant. And so this is why I never feel bad when patients come to my office or reach out and say, oh, I'm wearing my Apple Watch and it says I have atrial fibrillation. It's not always accurate. It may simply be ectopy, frequent ectopy, and it may not be AFib, but I would rather overcall it and prove that it's not AFib and keep somebody safe than to, miss it. I'm not advocating that everyone go out and buy a smartwatch or a smart app and be paranoid about their heart rhythm. But I'm saying that nowadays, the chance of somebody being in atrial fibrillation asymptomatically between office visits and other devices that they may have is getting lower and lower year by year.
Thank you so much, Dr. Cooper, for going through what still seems to be an inextricable link, as Naima alluded to earlier, between atrial fibrillation and flutter. I would love to dive more into the topic, but it looks like we just got a consult for a patient in the medical ICU. We have a 56-year-old woman with hypertension, diabetes, and cirrhosis who was admitted to the ICU with septic shock and is now on low dose of norepinephrine without a previous history of atrial fibrillation or flutter. And she was noted to be tachycardic in the 150s, and a regular narrow QRS rhythm was noted on telemetry. EKG was obtained and showed atrial flutter with 2-to-1 block at a rate of 130. The patient is hemodynamically stable. The primary team is asking us for our thoughts on the management of his atrial flutter. So, Dr. Cooper, I know you alluded a little bit to this earlier, but what is your approach to acute management of this critically ill patient's atrial flutter, and how does it differ from the management of atrial flutter in the outpatient setting?
Yeah, that's a great question. And I like the scenario. There are two components, of course, the short term and the long term. If somebody is ill in the ICU, certainly atrial arrhythmias are more common. And so in the long term, starting with that part first, once somebody gets better, which hopefully this patient will, the chance of them having recurrent arrhythmias of the same type that we were seeing while they were critically ill on pressors, et cetera, is actually on the low side. And so this is not the kind of person that I would necessarily, if they've never had a history before of atrial arrhythmias, that I would necessarily worry about long term. Probably we would watch them for a period of time on anticoagulation and maybe on some AV node blockade. And if they didn't have recurrence after a period of time, maybe several months, depending on the discussion with the patient, we might sort of stop it and say, okay, that was a situational arrhythmia. But more importantly, managing it acutely. You're now limited because of the patient's hypotension needing pressors in what you're able to do in terms of slowing the rate. You can't really give a beta blocker because that's paradoxical with respect to supporting their blood pressure. And the same goes for diltiazem or verapamil. Digoxin tends to be a relatively weak AV node blocker. It works by facilitating vagus nerve tone to the AV node, which is overwhelmed by the catechols in the setting of acute illness. Amiodarone has AV node blockade, so we will often turn to that, not for its antiarrhythmic properties necessarily, but more initially for its AV node blocking properties and lack of dropping the blood pressure. And if we, however, find that a patient is decompensating because they now have a tachycardia on top of their pre-existing hypotension from shock, then we may want to get them out of atrial flutter very promptly. That could take the form of an electrical cardioversion at the bedside in the ICU, especially if the patient's already sedated and intubated and therefore doesn't require additional anesthetic in order to keep them comfortable at the time of a delivered external shock. Then one could just simply proceed with shock delivery, and that could be repeated if the atrial arrhythmia recurs. Another option, if the patient, let's say, is awake and is too hypotensive to even tolerate anesthetic agent, then one could give a medication to chemically cardiovert the patient. And interestingly, amiodarone is the worst drug in this category to achieve acute cardioversion. There's a medication called ibutylide, which is in the class 3 category, and it is given intravenously in 1 or sometimes 2 doses if the first dose doesn't work. It is an intravenous version similar to dofetilide, as you might have guessed from the similarity in their names. Ibutylide will prolong the refractoriness in atrial tissue. It also will do so in ventricular tissue because the drug goes everywhere. And therefore, patients given ibutylide need to be monitored for the risk of long QT induced torsade. That risk is lowered if the patient is pretreated with magnesium. So the risk actually can be reduced to 1 or 2%. But obviously, with the ability to monitor them and be able to defibrillate them if they should have a ventricular arrhythmia. But that can, I believe the numbers are something on the order of 70% of the time, chemically cardiovert the patient out of atrial fibrillation. And that number is even higher for patients with atrial flutter. So if the patient is awake and sick and you want to get them out of it promptly, then ibutylide may be your answer. And then once they're in sinus rhythm, then one may use amiodarone maybe as an antiarrhythmic to try to prevent further recurrence. But again, the main point there is rate control may be difficult to achieve. So rhythm control might be an urgent alternative if the blood pressure fell when the patient went out of rhythm and became tachycardic.
That was an incredible sort of just synopsis of in juxtaposition against outpatient care, inpatient care, very sick patient, obviously. And the management, as we heard, can be incredibly different. And there's obviously a lot to think about there. Before we close, I just wanted to take another step in talking about atrial fibrillation, atrial flutter. We've been going back and forth about these a lot. We've talked about mechanisms. Obviously, stroke risk is prominent, and reducing stroke risk is a major portion of treatment in both of these. And one could hypothesize that the more regular atrial contraction that is happening in atrial flutter as opposed to atrial fibrillation could potentially reduce the risk of stroke, more blood flow moving through the atrium, et cetera. But I just wanted to touch on that a little bit. And if you could speak to the outcomes in atrial flutter as compared to atrial fibrillation in terms of stroke risk, as well as larger things like morbidity, mortality. And we've already sort of talked about recurrence after ablation and the success of ablation in atrial flutter. So could we just sort of highlight some of the other differences between atrial fibrillation and atrial flutter?
Yes, I'm actually going to instead highlight the similarities. It's very easy and tempting to think of the two as being different because if one were to look, for example, with a transesophageal echo procedure at the left atrial appendage in fibrillation versus flutter, the chaotic activity in atrial fibrillation will result in what appears to be less uniform and coordinated contraction of that left atrial appendage in fibrillation, as opposed to flutter, where you can actually see it contracting, albeit extremely rapidly. And therefore, one might conclude, based on the visual appearance of the left atrial appendage in the two scenarios, that the risk of clot and stroke is higher in AFib than a flutter. And therefore, there might be a perception that anticoagulation may be less necessary or less important for atrial flutter. Unfortunately, studies have not really borne that out, and patients are at risk for stroke in both, and to the point where the risk-benefit balance favors anticoagulation in both. In both cases, there is reduced blood flow coming out of the left atrial appendage just simply because at the rapid rate that is occurring in atrial flutter and certainly in atrial fibrillation, the amount of blood ejected from the appendage is not nearly what it is in sinus rhythm. And therefore, the recommendations are identical in the guidelines for atrial flutter and atrial fibrillation with regard to stroke risk reduction. And that would obviously be anticoagulation primarily. The biggest difference, as you said, is the ability to prevent recurrence using catheter ablation. And with atrial flutter, the cure rate is so high that we typically will monitor them for a period of time, as we discussed earlier, and then perhaps stop anticoagulation, being cognizant of the fact that such patients may be at risk for future atrial fibrillation, which would be then again a new diagnosis and would be managed separately. In contrast, because atrial fibrillation is a much more complicated rhythm, we certainly can do well with catheter ablation these days, but the fibrotic process that occurs as we age will continue to occur. after a successful atrial fibrillation ablation. And because the mechanism is far more complex in terms of firing sites and many areas of reentry, and perhaps the autonomic nervous system is playing a role at ganglionated plexi in the right and the left atrium as well, the cure rate of atrial fibrillation in the long run is far lower than that of atrial flutter, especially the longer one follows the patient. So we generally do not stop anticoagulation in patients with atrial fibrillation even after catheter ablation. That's changing a little bit with the long-term monitors that I mentioned earlier. And there are studies that are being done to look at whether patients who have atrial fibrillation ablation and maintenance of sinus rhythm for many, many months and being vigilantly watched with implantable monitors, whether one could adopt a strategy of stopping their anticoagulation, watching them closely, only to start it back up if they were to have a future event. But again, to summarize, the risks are very similar between the two, and the recommendations, therefore, are similar between the two. And the same goes for rate control, because patients can develop a cardiomyopathy, a reduction in the left ventricular ejection fraction, if they have sustained tachycardia for weeks or months on end. That risk is the same for atrial flutter and atrial fibrillation, and therefore they both should be managed at a bare minimum with rate control to make sure that the heart rate is below 90 typically would be ideal. But again, because atrial flutter is curable, we typically don't think about rate control as a problem in the long term because we can usually have successful rhythm control. The other point to make again is that of the post-cardioversion or post-ablation setting in both atrial flutter and atrial fibrillation, because the atrial myocytes have changed the way they handle calcium if they have been in durable atrial flutter or durable atrial fibrillation for a period of days or weeks or longer. When the patient's atrial rate suddenly slows from 300 or 500 down to 60 or 70 or 50, the calcium levels inside the myocytes plummet for a period of time until gene expression changes in such a way to allow the calcium levels to restore. And you get this mechanical stunning effect after each. And therefore, whether it's AFib or aflutter, if someone is in that rhythm and has sinus rhythm restored, the most important time to maintain anticoagulation, because it's the highest risk of stroke, is in the immediate post-cardioversion phase for at least several days and probably out to 2 to 4 weeks.
Dr. Cooper, this has been such a masterclass on everything atrial flutter, from its pathophysiologic mechanisms to both inpatient and outpatient management options to similarities and differences from atrial fibrillation. So just want to thank you for that. And as we come to a close of this phenomenal deep dive into the world of atrial flutter, would you please just give us a summary for our audience, just the key takeaways regarding the management of atrial flutter in our patients?
I'd be happy to. I think I will start with making the diagnosis. In my experience looking at telemetry and EKGs and seeing people who may not be electrophysiologists or even cardiologists interpreting the cardiac rhythm, the biggest mistake I see in the management of atrial flutter is failure to diagnose. I have seen patients be in atrial flutter and it is thought to represent sinus tachycardia because the patient is in 2-to-1 AV conduction and every other flutter wave is hidden in the QRS or in a T wave, and it is not recognized that there's a 2-to-1 atrium to ventricle relationship. It's the reason that in the series that I created on telemetry interpretation, the very first video that I made was the diagnosis of 2-to-1 flutter, because it's the biggest mistake, the biggest missed diagnosis that I have seen personally in patients in the inpatient and outpatient setting. So the first and main point of managing atrial flutter is be aware that if a patient has an SVT, a tachycardia, and there's no obvious explanation physiologically for why they should be tachycardic, have atrial flutter in your mind as a possible diagnosis and look very carefully at a 12-lead EKG or ask a friend to help you interpret it to see if in fact there might be atrial flutter lurking there, because the patient may be at risk for stroke. And if the flutter is not diagnosed, then that risk cannot be mitigated. And then, of course, there's the risk of tachycardia cardiomyopathy if somebody's left in an atrial flutter that's not diagnosed for a long period of time, meaning weeks or longer. But in terms of once it is recognized, it is such a curable condition that typically, even with a first episode, catheter ablation is often first-line therapy with a period of anticoagulation that often can be stopped if atrial fibrillation hasn't coexisted. And if the patient is not interested in, or there is a specific situation that it's felt that atrial flutter was triggered by that situation, then starting with cardioversion is very reasonable, watching for recurrence, and then on the second or third occasion, proceeding with a flutter ablation. So recognize it, treat it early, treat it often, and the patient can cross it off their list of medical problems.
Awesome, Dr. Cooper. What an amazing way of putting everything into a nutshell. It has been such a pleasure to learn from you. As is the CardioNerds tradition, we would love to hear from you what about atrial flutter makes your heart flutter, and actually to speak more broadly, what about electrophysiology education makes your heart flutter?
I think that electrophysiologists love atrial flutter because it is such an elegant rhythm. It really demonstrates the principles of electrical conduction across tissue, the concept of reentry, the concept of refractory period, the concept of conduction velocity, the concept of anatomy. So many basic concepts come together in the form of atrial flutter, the concept of entrainment, and so there's nothing, if you understand flutter, you understand electrophysiology of the heart, because all of the basic principles from the cell to the chamber to the organ are all demonstrated in atrial flutter. And that's why I love it so much. And I'll give one last little anecdote. There have been, at least on 2 occasions, medical students who have found themselves wandering into the EP lab because they have a patient on the inpatient service with atrial flutter. And they were curious what goes on in that mystery place, the EP lab. And they decided bravely to enter our realm, and thankfully so. And we sit down when they come into the lab, and I draw them the circuit. I show them what we're looking at on the screens, and they can follow along as we ablate atrial flutter, and it slows and it terminates, and they're in sinus rhythm, and it just feels like magic. And in these cases, the students have been so impressed and excited about atrial flutter that they went into cardiology and they went into electrophysiology. And so I guess this serves more as a warning that if you find yourself in the EP lab environment surrounded by or near an electrophysiologist who's talking about flutter and you haven't yet picked a career destination, beware that you might end up inadvertently finding yourself influenced to become an electrophysiologist because of the magic of atrial flutter and learning about it. So I am passionate about education, and please, anyone is welcome to come by and learn about atrial flutter and other electrophysiology topics. And likewise, you can learn asynchronously online. And that's why I love teaching in every capacity. And nowadays, especially after the COVID pandemic, the concept of lectures online exploded. There are so many resources to learn about so many areas, electrophysiology included, that I would encourage people to use those resources, whether it's on YouTube or other educational sites, to teach yourself. I think personally, visual learning, watching videos, listening to somebody explain and demonstrate something rather than reading it from a book tends to be my preferred learning strategy. And I encourage people to, again, take advantage of those resources.
Awesome. Thank you so much, Dr. Cooper. That was some great advice. And I must say, I'm sure everyone in the audience can appreciate how excited you are about Flutter and about electrophysiology in general. And I'm sure there's people in the audience that are more thrilled to hear about this and will certainly want to learn more about EP in general. Thank you so much for taking out time to talk with us today. And we are very excited to learn more using your YouTube channel as well as the other resources that you mentioned. Thank you so much, Dr. Cooper.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Bhavya Shah. I'm an intern in the CardioNerds Academy House, Eindhoven, and a fourth-year medical student at Rowan Virtue School of Osteopathic Medicine. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.